I'd like to welcome all of you to a seminar that we're doing on building a medical oxygen system, essential considerations. This is co-hosted by Assist International and Invest India, and generously sponsored by the Caterpillar Foundation. My name is Sherry Reynolds. I'm the Director of Global Health and Program Development for Assist International. And first and foremost, we would like to extend our deepest sympathy and heartfelt condolences for the dire situation around the world that so many people are currently experiencing, and the devastating loss of life due to lack of oxygen from the COVID-19 pandemic. Assist International and the other panelists that will be joining us have been working for years to improve access to medical oxygen in low and middle income countries. We believe that our experience in the field will be of benefit to you as you address the dire need for oxygen supply. And our goal tonight is to share with you best practices and technical guidance that we have learned along the way in the hopes of expediting your process for planning PSA plants to supply oxygen. I'd like to welcome and give a moment for Ms. Drishti Joshi from the Invest India team to welcome you all.
Thank you so much, Cherie, for that warm welcome. Very good evening to everyone who's joining us today. I just want to thank you all for taking out the time from your very busy schedules. I'm very well aware of how much everyone is stretched currently at all levels from central to state governments. And in fact, we also have some district governments joining today. So thank you again for taking out that time. This session is going to be very, very useful because as you know, we are kickstarting that endeavor of building PSA plants in India. And Assist International has, immense expertise in building such oxygen capacities across the world. And they have done so in many, many countries. So it will be very useful for us as well to tap into the expertise that they have. And I urge everyone to, shoot whatever questions they have to Jim, who, is the expert that Assist International has. And they very kindly agreed to do this sort of introductory session. If the session is useful to you, you can actually take forward, relationships with Assist International as well. And they would be able to provide you further support and handholding with regard to, sort of kickstarting the building of your PSA plant, making sure that, it's built in the most efficient manner possible, and it's also managed and maintained in the best fashion possible. As you are aware that maintenance is always a big question. Construction is often quite easy. That is also something that Assist looks after. So without taking much time away from this very informative session, I'm just going to stop here and hand it over to the folks at Assist to take it forward. Thanks so much.
Thank you, Ms. Joshi, very much, and thank you for being a part of this. I'd like to introduce to you Mr. Jim Stunkel. He is the Vice President at Assist International. He is our oxygen expert. He has a background as a first responder and has done medical projects all over the world. He has a deep understanding of the components needed for the design and installation of PSA plants. So Jim, can you just start us off, please?
Thank you, Sherry. I'm going to share my screen here, if I may. Do you see my screen? Okay, yes, so we're going to begin today our presentation sharply with acknowledging that our assumptions today are for the India context. We understand that India currently has significant liquid oxygen production. That's great, and that actions to increase distribution to this resource are underway. We also know that concentrators are well understood across India, and many concentrators, again, are being procured and distributed. And as well, hundreds of PSA plants are currently and being provided or soon will be. And the presentation here today will focus on the context of the PSA plants in particular. So here we go. We're going to discuss a comprehensive ecosystem approach to providing medical oxygen. There are 5 barriers that prevent patients from receiving oxygen, and we want to address those barriers. That's oxygen availability and accessibility, oxygen therapy equipment, clinical and technical training, national and policy effective advocacy, and market demand and supply chain and local expertise. So what's the process? Well, number 1, we want to plan what needs to be done, identify the scope of the need we want to address, and then conduct a need gap analysis. Phase 2 will be to design interventions based on the scope and the need and the ability to execute. And then phase 3 will be to implement. That will be the site development, the installation of the equipment, and the management of the entire program. Finally, the production and distribution operations. So phase 1, let's discuss the planning. Identify the scope of your need. It may be the state level or district level, maybe even your leader just for a tertiary hospital service area. We want to identify the scope of essential considerations for your oxygen program, and then conduct a need gap analysis. What's the forecast level of need? And what's the current baseline capacity to meet any need? And then the gap is the forecast need minus the baseline supply capacity. That's what we want to assess so that we can close that gap. In the need gap analysis, we ask the question, where are the gaps for each of the essential considerations? Each one of these considerations is essential and needs to be included in a comprehensive oxygen program for your state, for your district, for your tertiary hospital, or the regional area. Oxygen production, essential. Consider power supply, essential. Distribution system, what is the distribution system that you have available? What's the gap? Delivery equipment, do you have trucks? Do you need to acquire them? Accessories and consumables, do you have them or are they not available? Training, is it available or do you need to create it? Spare parts, maintenance, sustainment funding. Each one of these is an essential consideration for a comprehensive program. We're going to focus on first the PSA equipment itself. You may have a plant or desire to have a plant with cylinder filling capacity, or a plant that's connected to pipe systems that are direct to the hospital. A plant with combined cylinder filling and to pipe systems is also an option. And then PSA operations, planning for that. A plant management team will be needed and may manage multiple sites. And qualified biomedical engineers should be appointed as operators. So here's some details regarding the PSA plants themselves. The design and cost is different for each manufacturer, but the features are basically the same. And you can see the illustrations of 3 different plants. AirSep Corporation comes from the USA, Oxymat comes from Europe, and Built by High-Tech comes from India. The PSA plants are built to order, and 16 to 64 cubic meters per hour is common. Cylinder filling capacity is a separate feature of a plant and a separate cost. But here's a production comparison. I know some have been interested in this. One 32 cubic meter per hour plant is equal to the volume of oxygen of about 53 concentrators producing at 10 liters per minute. So there's just a quantification comparison. Power supply, just as essential as your operating plant because the plants require powers 24 hours a day. You must have a plan for it. We're going to have more on this from Jim Ansara from BHI, but the power from the grid needs to be established, or power from a generator, maybe a backup generator or a primary generator, power from both. And it's best to provide a dedicated power supply. That is, this power supply should go only to the plant, not to the hospital and some other part of the hospital, but just to the plant. Provide a budget for the power cost for your grid power or for the diesel fuel. Don't let that consideration gap hold you back from having the plant to operate because you ran out of diesel fuel. Consider the cylinder advantage. When cylinders are filled, there's no power required after filling. And then oxygen concentrators, again, always requiring power. So power is a cornerstone of an effective oxygen program. Here's 2 images of distribution and delivery systems. Option 1 is direct piping from the PSA plant to the bedside. And you can see the components of the plant and then the green cylinders that are attached as a backup supply should the plant need to be serviced. And then the blue line that goes across the view over to the hospital beds. That's a direct piping system, in which case the plant needs to be very close to the hospital, maybe on an exterior wall or an adjacent building. That's a direct bedside supply. Option 2 is a PSA plant to a remote location. Yes.
Apologies for interrupting. Could you just speak a little bit slower for our attendees?
Yes, I can.
Thank you.
That's all right. Option 2 is the PSA supplies to a remote location. In this case, the PSA plant may be not on site at the hospital you want to serve, or maybe you want to serve multiple hospitals. But in this case, you would fill cylinders, and you can see in the red circle, that's a cylinder filling compressor. That component is added, and then cylinders are delivered by truck or by hand trolley, shifting to the hospital, either to a manifold and a pipe system that's remotely located, or to the bedside of the patient. Here's a detail to consider regarding the distribution and delivery of cylinders, and that is how many cylinders are needed for such a program. The answer is 3 times the number of cylinders that would serve the patients, because the first cylinder is actually serving the patient. But when that cylinder needs to be filled, it needs to be transported by truck to a filling station. So you need the first cylinder in process of oxygen therapy, the second cylinder at standby or in process of transit, and the third cylinder at the PSA plant in the process of filling. So plan your need gap analysis to consider how many cylinders do you really need to serve your patients. Accessories and consumables are essential for everything to get the oxygen into the lungs of the patient. There are some sad stories recently of oxygen being available in a cylinder, but with no regulator or no flow meter. And many clinical healthcare providers may not have the tools such as pulse oximeters to even be able to assess their patients, to be able to prescribe the proper therapy. So please consider all of the accessories, not just an oxygen plant. That won't be enough. You'll need cylinders, pulse oximeters, regulators, flow meters, humidifiers, cannulas, masks, tubing, splitters. We can make this list available to you and more, but this is part of the need gap analysis. What do you have and how much will you need? This needs to be part of your budget and part of your planning. Training. Please don't forget that training is an essential consideration for an effective oxygen program. First of all, the training for the PSA plant operators. It should begin at the time of the plant installation. They should be trained for operations and for service of the plant. And follow-up training can be provided by service contract provider from your region. Clinical training for doctors and nurses and other medical staff. Oxygen therapy and the proper use of therapy equipment is essential to being able to have a good and effective medical oxygen program. It's often overlooked or underfunded. So consider what is the need and then the gap analysis to be able to provide that clinical training. Clinical training programs can be in person or can be remote, such as through webinars, live and interactive, and many resources are online to access remotely. Spare parts are required or your equipment will fail. Consider the gap of what parts you may have and what you will need for your future program. Advanced planning is essential for PSA plants. Anticipate the required routine service schedule. Know what that is from the time you're procuring your plant. How often will you need to service it? Every 6 months, every year? Typically, there's a different schedule for different components of the plant. And pre-order at least 2 years of essential spare parts, and then reorder whenever the parts are used so that you never will run out. Establish the supply chains at the time of procurement so that you are not looking for parts later, but you know from the time you procure your equipment where you will supply yourselves in the future when you need equipment to be restocked. Maintenance is also required or the equipment will fail. Don't wait until the equipment fails before you look for service. As part of your initial planning for your comprehensive program, appoint biomedical engineers and hire the most qualified local personnel that you can. And they can serve as both the PSA operators and the PSA service providers. The maintenance requirements should be strictly followed according to the PSA manufacturer guidelines. This is an important consideration for ensuring that the plant is operational. And then establish a service contract if needed. First, obtain a service by an authorized PSA representative, but then second, build the capacity of your own local team. In the future, they'll be well suited to be able to provide the service you need. Sustainment funding is required or equipment will fail. So please consider advanced planning for the entire scope of the project, for your operations expense, your services expense, and your spare parts. If you're not able to provide these funds, I would say scale down your program. Make a commitment to the funding source. And typically there are two options for funding. One, you can fund the PSA by government allocations, could be state, federal, local levels, but some direct government allocation, or fund option two would be to fund the PSA by selling the oxygen from the production. There'll be more about this later from Dr. Bernard Olo from Heratella and Center for Public Health and Development has worked extensively for these kind of systems, the hub and spoke model for manufacturing and distribution. This is where a central location produces and distributes for a sales program to the regional hospitals. Phase two are design interventions. So design based on confirming the scope of the program that you want, prioritizing your objectives, and then establishing the implementation plan. Phase three will be a coordinated project management. You'll confirm the scope of your program, whether it's locations and scale, and then confirm the budget, funding for priorities, and then you can set your plan. You may not be able to establish a plan for your entire state or even your entire district, but do a thorough plan for the entire ecosystem within the scope that you are able to support. Basic considerations, of course, is the build and construction. As Dershti said, the construction is maybe the easiest part. We know how to build buildings, but an oxygen plant building needs consideration for security, that's special, logistics for oxygen to be distributed either by direct piping or by truck, environment that's with limited amount of dust or smoke, and there needs to be a production area, an office and storage area, shipping and receiving areas, and washing areas outside. An example of the oxygen plant building and then a dedicated power transformer. Coordinate the schedule for construction of the building and the installation of power to align with the delivery of the PSA plant, so that when the plant is delivered, you can manage that delivery and installation as efficiently as possible. Make every provision for adequate staffing, proper hand and tools that you need for installation. The manufacturer will guide you on the proper installation of the plant and should accompany you. The factory installation team can train and certify the appointed biomedical engineers as qualified oxygen plant operators and technicians, so that your local staff will be able to do all of the operations going forward. Coordinate your pipe and distribution systems. Maybe you won't be able to install pipe, but I highly recommend it. We'll have more on this from Jim Ansara from Build Health International. There's small pipe systems for each ward or department, or a larger system for an entire hospital. Consider the management of the operations. PSA oxygen production and distribution will begin, and you will be having an effective oxygen program based on these essential considerations and planning. This is the end of this presentation. I want to thank you for your attention here. We know that oxygen saves lives. I'd like to make acknowledgements of the open source material from World Health Organization, the Health Emergencies Program, from PATH, their Oxygen Delivery Toolkit, Electricity Planning Guides, Partners in Health, Build Health International, they have technical toolkits, and Every Breath Counts. Thank you. Sherry, back to you.
Thank you so much, Jim. And we recognize that this is a lot of information. We will be sending up follow-up information, and also would encourage you to put any questions that you have into the question and answer box. And we'll do our very best to answer them during this time. Although time is limited, we will have some follow-up information and answers to your questions that we provide as well. Next, I would like to introduce to you Ms. Laura Alejandra Velez Ruiz Gatan, who is with the WHO. She has a background in clinical and biomedical engineering, and she is the technical focal point for the Oxygen Access Scale-Up Initiative at the WHO. Ms. Velez Ruiz Gatan conducts quality assurance and reviews specifications of the biomedical equipment and oxygen sources procured by the WHO. She has extensive knowledge of the WHO COVID-19 response, and today we welcome her to talk to us about the various resources the WHO has available to assist you with your oxygen planning.
Thank you, Sherry. Yeah, nice to meet you. I was going to share the screen to share some of the slide deck, but let's go straight to this one. Yes, I don't know if actually you can show the previous one to show the website. Where is it? Yeah, okay, thank you. So we have been working together since June, like last year, together with our team of procurement, clinicians, and logistics to build together this initiative and bring up all the guidelines that have been present, that has been developed in WHO. So we are now compiling them, or the links in this website that you can access. We will be uploading some other tools. The idea of here is to integrate, as I said, information from the medical devices, clinical department guidance, and the innovation team. We are also linking to the information of the International Pharmacopoeia, that it's the one that will be soon updated to include the oxygen produced by PSA or BSA systems, that is the oxygen 93. As you know, it has been a concern in some countries because of the discussion about the purity or an impurity remining. Also, it will be a link to the good manufacturing practices of medical or therapeutic oxygen. That is work done in another area of WHO. We are also connecting with the partners publicly available tools, including some calculator tools for the oxygen demand at world level. And we have the WHO tools that you will see in the next slide. And we are also linking to the webinars and the updated news of the work done. Next slide, please. Okay, so based on the discussion already that Jim gave to you to understand what is the ecosystem of the oxygen and all the considerations that you need to have to build or to procure and to install a PSA plant, we have been developing some of the tools related to this. So the first one is the Rapid Biomedical Inventory tool that it's on the web since last year, and it's all the COVID related equipment. Then we have the estimation of the oxygen demand facility assessment tool. As also Jim mentioned, there are many approaches to estimate the oxygen demand, and there are many user factors that needs to be considered to come to an appropriate sizing and configuration of the PSA plant. There is no rule of thumb, because you need to understand all the context where the systems will be implemented. There is also a tool for assessment of liquid oxygen suppliers for existing oxygen generator plants, so to see what is the status and the maintenance that has been provided. There is also the technical requirements to procure oxygen generator plants, which include the service agreement considerations, spare parts, commissioning, and one of the important components is the shipping. We have seen that this is a cost driver for the procurement of the PSAs because they have specific considerations in size and how to transport them. There is also some formats for site evaluation and preparation, and this is to help to the end user to understand if they have the correct space, as it was explained also before, and to allocate the plant and to do the air separation for oxygen. There is also the holistic biomed bundles, that this is work started since last year, also putting the biomedical equipment with all the necessary spare parts, consumables, and accessories to be operable, and the quantification for a certain period of time. There will be also some work that we have done with the clinical team, that is the home care bundle and the rational use of therapeutic oxygen. And there will be also the biomedical training videos of the equipment related to the COVID response also. And we have published the oxygen fire risk mitigation measures that we consider is something very important now that cylinders have been transfer also for home use. So you will find here some recommendations trying to, it should be that only cylinders for medical use of oxygen should be used. You don't need to plead with certain substances, etc. So I invite all of you to join the link, to click in the link, and to also, if you have questions or need more assessment, to write to us so we can further support. Thank you.
Thank you so much. That is wonderful. And we will be sending out the link for you all for all of the WHO resources. Next, I would like to introduce to you Dr. Bernard Olo. He is a Kenya physician and public health specialist with more than 14 years experience as an African healthcare system. He's also an entrepreneur and the founder of a nonprofit organization called Center for Public Health and Development. He also runs 2 social enterprises working toward improving access to quality healthcare in Africa. These include the medical oxygen company Heratella and a medical equipment social enterprise called MedEquip Global. Dr. Olo is also a technical team member for several World Bank programs in East Africa and an advisor to several ministries of health in the region, with the focus on enhancing the role of private sector in improving access to health services and goods through public-private partnerships. Today, he's going to discuss with us the importance of building a sustainable oxygen solution and the value and intricacies of a public-private partnership. We'd really like to welcome you, Dr. Olo.
Thank you so much for having me today. I hope you can hear me well.
We can, thank you.
Thank you. So our journey to running Heratella was started with Assist International as a partner, and we really want to thank you for that opportunity to get us started. But it did not start with success. So I was quite happy to hear what Jim was outlining as areas where things could go wrong, because starting as an NGO with funding from GE Foundation, we identified oxygen as a problem or as a major gap in our health facilities. Earlier in my career, I was running government health systems in rural Kenya, and one of the main challenges that we were facing was the lack of oxygen, where sometimes I could do a cesarean section, or you had a sick child and you saw the child die because you didn't have oxygen. So we wanted to find a solution. And the solution that we came up with first, working with G Foundation and Assist International, is quite similar to what I'm seeing right now with COVID-19, where we say, why don't we buy them the equipment and donate it to them? So we had a donation of small PSA plants to 14 hospitals across East Africa, in Rwanda, in Uganda, and in Kenya, and I think in Tanzania also. But despite every effort that we had to keep these technologies working, in 2 years' time, they were all down. They could not produce oxygen anymore. We still have one in Siaya at our museum as a reminder of where this journey started. So that challenged us to exactly identify what could really go wrong with the PSA plant from our experience. One was that if there's no plan for maintenance, and we didn't have a proper plan for maintenance then you get into trouble in a very short time with spare parts, with some of the consumables necessary. The second problem was that if you don't have a local capacity to fix the equipment, then you can also get into problems. And that can even be worse when you have a situation like now where we have COVID, and if you can't travel, or if the experts cannot travel from abroad, then your equipment won't work. And thirdly, I think we had not sized the equipment correctly. You need to do the needs assessment, and in selecting the equipment, we need to provide the right capacity for the appropriate health system. This equipment that we provided initially were too small, and the hospitals just ran them 24/7 until they stopped working because the hospitals were thirsty for oxygen. So then that pushed us to the second phase where we are today, which was like, how can we improve on this experience? And the solution we came up with was a product that takes away the responsibility of maintaining or running the oxygen plant away from the hospital. So we designed a much bigger plant that we manage ourselves, we maintain ourselves, we control everything around it, and then we produce and distribute oxygen in an optimal way to a network of hospitals within a radius of approximately 100 kilometers. That is the Heratella model. So today in Kenya, we are serving close to 150 hospitals out of 3 large plants, and we are soon going to be expanding to other regions. And the way it works is that we produce oxygen, we run the plant, and we bring the oxygen to the hospitals and take out the empty cylinders on a daily basis. Now, this model has allowed us to reduce the price of oxygen compared to the existing market price by approximately between 40 to 50%, depending on the distance from the facility where we are producing. And we have also done everything that Jim described earlier. We do the training. We don't want to see ourselves as an oxygen selling company, but we want to see ourselves as a solutions provider that bridges the gap between the oxygen production and the patient's lungs. So over time, we have identified sources for all the accessories that the hospitals need. We do piping, we provide pulse oximetry, we do training for biomeds, and we also do we do the training for the clinicians, just to make sure that the whole cycle is complete. In total, we have seen that model to work very well for us, and we tested it quite strongly during the 2 episodes of the COVID spikes in Kenya. The most difficult one for us was in February, March this year, when we had to run the equipment or the production facilities 24 hours a day, almost for 2 weeks nonstop. We're working every day to meet the demands of our clients. And to do that, we hired more staff. So more about these plants is that they're easy to run if you have the right people. For each plant, we just need around 5 people, someone that does the paperwork and admin type of work. Then there's a biomed that does the maintenance and daily check-ins and supports production. You have a driver that takes oxygen round, and some 2 other people that just help with the production and cleaning of the facility. And it's self-sustaining because we get into a public-private partnership agreement with the governments for all these 3 plants. We set it up at the near the facilities of the most or the busiest facility, so that we don't have to incur a lot of travel costs to bring oxygen to them. And then the surplus we distribute to both public and private facilities within the area that I've described. So we see this as a sustainable model because the hospitals are happy to pay. We get into a 5 to 7 year contract. We started in 2014. Our first contracts have expired, but because of the good services have been renewed. So we are going to continue doing this for the foreseeable future. So it's a model that I think addresses some of those key challenges that Jim identified earlier. For us during COVID, one of the main problems that we faced, which is a learning point for us, was just inability to source parts for our oxygen booster, the Rex compressor. The company shut down for some reason because of COVID in the US, and we just couldn't get our parts in time. So in future, we want to make sure that at least we stock enough parts for a longer period of time to be able to meet the needs of our clients. So we want to share this. We will share some write-ups with the Assist team, and they'll share with everyone, plus my email. We are very happy to share the experience with you. We've done a number of videos on it that I can also share with you to, share the learnings that we've come up with over close to the last 10 years for anybody that wants to get into this business. But happy to take any questions from the team. Thank you.
Thank you so much, Dr. Alea, and hopefully you can stay on and we'll get to the question and answer time because we do have some questions for you.
Certainly.
Great. Our final speaker today is Mr. Jim Ansira. He is co-founder and managing director of Build Health International. He has a background in commercial construction, founding one of the top 25 construction companies in the United States. He has extensive experience with commercial building. And today he is going to share with us critical factors to consider on oxygen piping and power requirements. Thank you, Jim.
Thank you, Sherry. And I apologize to everyone for being late. I was on another webinar and trying to balance these, so I appreciate everyone's patience. Just a bit about Build Health. We are architects, engineers, and technicians and builders. We design, plan, engineer, and build healthcare infrastructure for NGOs and ministries of health in low resource settings. So as a result of that work, which we've been doing for 12 years, oxygen and energy are critical in all our work. So that is how we sort of come to this. Jim Stunkel asked me to just talk about some of the practical lessons learned over the last 12 years in terms of installation of PSA plants and pipeline. So that's what I'm going to try to address. Next slide, please. So in terms of installing PSA plants for longevity of service, the successful installation really begins and ends with clean and consistent electricity. And this is very much misunderstood by many, many people in terms of the details of this. Everyone has seen examples like the photos we see of poor electrical installations and engineering in low resource settings where electricity can be extremely challenging. For PSA plants, it is not just voltage that is a challenge, but also harmonics and frequency. How clean the power is, especially if you're getting power from the utility grid, is really, really important. And it can just play havoc with the system and really minimize the life of the plant. When our first project, which was the National Teaching Hospital for Partners in Health in Haiti after the earthquake in Mirebalais, we connected to the grid, which was serviced by a dam 20 miles away that was being improved by bilateral funders. And this just created havoc with all our big motors, including our PSA plant. We had anticipated the voltage issues and put voltage regulators, invested heavily in voltage regulators, but that didn't do it. We had tremendous fluctuations in frequency, which ended up burning out the main motor on the compressor, a 25 horsepower motor, within a matter of months. And we ended up, in fact, detaching from the grid and putting solar in, and the hospital today runs on solar and generator. So I can't emphasize enough that it's not enough to just look at the voltage or have the system reset if the voltage drops. You have to look at other factors. Next slide, please. This is that hospital, the Mirebalais Hospital. You can see we have 1,800 solar panels. We're currently trying to do a second phase, which would double the size and battery capacity. Next slide, please. Environmental conditions in tropical countries are absolutely critical and again, often overlooked. Heat is the enemy. This is an installation in a very hot country where even though 2 wall fans were provided. This is not adequate for venting this room. And we would advocate, we typically put multiple ventilation sources, including a hood over the primary compressor with a mechanical fan. People constantly underestimate the need for ventilation for PSA systems. And it, again, really shortens the life of these systems. We believe that piped oxygen is a right, that every hospital in every country should have oxygen at the bedside. I would not want a family member, my mother or father, to go to a hospital in critical condition or even just ill and have to be treated with a portable oxygen concentrator at 10 liters a minute. We have to change our thinking about the delivery rates of oxygen and the availability of oxygen. High pressure cylinders can deliver high flows, but we have data that shows that we have much better outcomes when we have wall oxygen, such as this hospital in Haiti, right behind the patient's head. That's the expectation at every hospital in the United States and in Europe, and it should be the same in the global south as well. And I feel very, very strongly that this needs to change, and we need to stop with incremental thinking or thinking that 10-liter oxygen concentrators are good enough for the global south. Next slide, please. Oxygen pipeline is affordable and doable. We do it differently than is done in the US or Europe, but we feel it's safe, and we have had no problems in 12 years. Many of the standards that were developed for oxygen pipeline in the United States through NFPA 99 are a result of incidents that happened sometimes 40 or 50 years ago with operating room fires, which had many other reasons that happened and are no longer relevant. So it's time to relook at these standards. Next slide, please. As I said, the risk of the worst case pipeline or OR fires must be studied with data analysis and weighed against the critical risk of unaffordable, unachievable standards in the global south. There are many other things that we can do to lower the cost of pipeline. Simple analog alarms work as well as complex, expensive circuit boards and computer-based alarm systems that are prevalent in the US and Europe. Oxygen service copper, which is factory clean copper piping and bagged fittings, which are sometimes 3 to 4 times the cost of the same copper that isn't cleaned, are designed to save labor costs in high income countries. When I started doing oxygen piping 30 years ago in hospitals, there wasn't oxygen service copper piping. We cleaned it on site, and that's how we do it today. Next slide, please. The proof of this concept in terms of piping was the Mirbelet COVID Center that we did last summer for Partners in Health in Haiti. And this was over 100 beds of temporary buildings that were built and piped with oxygen by a 100% Haitian team that we had trained over the last 12 years. We did this for under $350 per bed for oxygen, which is a fraction of the cost that it would be in the United States. So this is doable. The team also did all the piping, testing, and brought it online in 2.5 weeks. Again, this was an all Haitian team. And, honestly, if you can do this in Haiti, you can do this in most countries. It simply takes the commitment around training and development of workforce. Thank you. I want to keep my comments brief because I'm sure there are other questions.
Thank you so much, Jim and Sarah. We really appreciate that. And power considerations are so important, especially I know in India, they're currently going to be facing a cyclone season. And so that becomes even more important. So we are now going to move towards the question and answer. There are so many questions, and we appreciate you putting those questions in. We are not going to be able to get to all of them, but we will figure out a way to do our best to answer those questions, whether it's in written form or some other manner. We will get to as many as we can. I'm going to start by just asking some questions from our panelists. If you feel, I'm going to ask you directly, but if you feel like maybe you would rather have someone else answer, feel free to do that. And Jim and Sarah, since you were the last speaker and you're still on, let me just ask you this question that came in. What threshold considerations should individual hospitals use to decide on their main and backup supply sources?
That's a complicated question with a complicated answer. Assuming you're in a country that doesn't have access to liquid oxygen, or if there is liquid oxygen, you're limited by the ability to transport it and store it, then we are huge advocates of PSA plants that flow low pressure oxygen into pipe systems. If you have access to purchase high pressure cylinders, you can eliminate the high pressure booster pump, which saves often $50,000 or more in capital costs and can save you about $12,000 a year in maintenance. The high pressure booster pump, I think Jim Stunkel and others would agree, is sort of the Achilles heel of the PSA tank cylinder filling systems. It is expensive and very difficult to maintain. Thank you.
Great, thank you. This question is for Dr. Alaya. What, in your assessment, is stopping governments from engaging in public-private partnerships for oxygen delivery?
Thanks, Cherry, for this. I think public-private partnerships are new. And what I've seen in most countries is that the public procurement laws are geared towards buying and owning things and not getting services, which is what PPPs are all about. And the earliest PPPs, and I think they're probably most developed in the UK, were very much geared towards extremely large infrastructure projects. So if you are looking at how to do PPPs, most likely you will get information or the tools on how to do a bridge, a port, an airport, or something like that. So services have not been the major concern of most of these PPPs, and you'll find that there's just not much experience. So to do a successful PPP really requires a lot of education or capacity building for government, for them to really understand what you're trying to do and demonstrate the benefits. The other common misconception that I see is that PPPs are supposed to be cheaper and that you're supposed to do them when you don't have money. In reality, they are not. What they should do is to guarantee you a more efficient service delivery and to take away the risks from the government to a party that can manage them in the best way possible. One last challenge that I see, again, still linked to government procurement, is that they want to purchase things or services and goods on an annual basis based on allocated government budget. So if you're going to get into a PPP to set up and operate a plant like Heratella plant, you need at least a 5 to 7 year commitment from the government or the public entity for it to make economic sense. And these are really challenges that can be overcome with a bit of demonstration of experience. So far, we are seeing it's the conversations with government or public entities have become much easier for us now because we can bring them to talk to their government counterparts where we have been implementing to see for themselves how it works and to discuss the benefits. So having an experience or some experience or that, a pilot of sort that they can go to and learn has been very helpful. But discussing it at a theoretical level was very, very difficult for us at the beginning. So it's changing. I think things are going to get better over time, but we still need a lot of hand-holding on the public sector side to make them come along. Thank you.
Thank you, Dr. Alayo. This question is for Ms. Velez Ruiz-Gatan. Can you speak to how can people assess the quality of oxygen as they're, putting in their plants?
Hello, thank you. Yes, if we are speaking directly to the plants, all devices, considering medical devices, should have a quality assurance process that is related also to the documents that the manufacturer could provide us or can provide us or certify from the manufacturing site. We have published the WHO technical specifications that help to have a generic idea of what will be the standards and certifications that you need to have in the output of the oxygen generator plants. If the plants are already installed and working and you want to monitor the oxygen purity, normally in the control panel, you will be able to look what is the purity that they are giving to you, and then you need to troubleshoot where is the problem, if so. But also you may ask the manufacturer or the authorized distributor to give you to provide you with the specific oxygen analyzers that can help you to do the maintenance and of course following all the change of the filters and on what is required in the maintenance programs. Over.
Excellent, thank you so much. And we will be sharing links to all of the tools that the WHO has to offer, as well as others that we have. I'm going to take one from the question and answer, and Jim Stumple, this one's going to go to you. It's from Dr. Pradesh, and it asks if you can give guidance on calculating the formula for determining the size of oxygen cylinder manifold system for standalone type and for type connected to PSA plants based on the number of beds to be connected.
Yes, we can. First of all, there are a number of tools, including within the toolkit that Alejandra from WHO mentioned, that can help you do these calculations. Those tools guide you to basically assessing the number of patients you want to serve and how many total cubic meters or liters per minute of oxygen that you need to produce. Then you will calculate according to your design whether that oxygen should be distributed through piping or through cylinders. But those tools are available. They are formulaic. We will provide some links specifically to the doctor that's asked this question and make them public. We'll magnify them so that everyone can see what those formulas are, essentially counting the number of beds you have for certain departments. There's a factor to multiply by, plus consideration for surgical centers and ICUs that take a little bit more oxygen. There's a factor to include. And then that will tell you what your target production rate should be. And then based on your own needs assessment, whether or not you're going to have a pipe system or a cylinder system, that will tell you the method to which you will make your distribution. Anybody else on our panel may have some other tips to add, but we can put, it is a formula that can be a guide, and we can make those formulas available.
Sherry, if I could add a few comments.
Yes, please.
This is really a complex issue that people really struggle with in both resource and low resource settings. Even in the USA, the guidelines for oxygen consumption, there are guidelines for oxygen consumption, but there's still a lot left up to the engineers. If you follow the British or American guidelines, you end up with PSA plants that are much too large and are very, very expensive to run, or a huge cylinder capacity that most find unachievable. Many of the tools that are out are better than nothing, but some of them we find also can understate, especially in the age of COVID, the capacity. It really varies from hospital to hospital and country to country. In countries where there is a very weak public health system and not many referral hospitals, we see patients, COVID patients, over 70% of the COVID patients getting to the hospital needing 20 to 40 liters of oxygen to stabilize them. And this requires huge amounts of oxygen. Depending on the mix of adults and peds and pediatrics, that can really vary because infants have very low needs. So I would just urge people in their sizing of plants to really put effort into this, because a plant that is too small is disastrous. That can impact the longevity of the plant and the purity level of the oxygen. A plant that's too large can also be very problematic. Thanks.
And Sherry, if I could just add something, the number one cost of running a PSA plant, especially if you have a filling component, is electricity cost. So the bigger the plant, the bigger the compressor, the higher your cost of electricity. So in places like Kenya, where electricity is very expensive, so we need to be very careful with the sizing so that you don't have redundant capacity that you don't need, that makes your operating costs go really, really high. And one other last point is that whatever we choose, it will fail. So every hospital needs to have one major source of oxygen and a reliable backup system. Yeah.
Thank you. That's very important. Dr. Olo, while you're there, there's a question that came in, and it asks, what is the disadvantage, maybe advantage as well, of highly pure oxygen that is used for medication? And they put in parentheses 99.9%.
So this is something that we've talked about a lot. From a clinical perspective, you really don't give patients 100% oxygen or close to 100. So I think the new WHO guidelines are saying that we should anything above 90% is okay. But even during surgery, you tend to mix oxygen with something else so that patients, because under normal circumstances, patients will be breathing, at 20% oxygen. So if people are given 100% for far too long, then reversal to normal use becomes difficult. So even during surgery, we don't even go close to 100%. So in reality, if we can give people 90 plus, it is good enough for when they're sick. I know because of the PSA production system using zeolite separation, we can't achieve 99%, but we can do very well with 93 to 95%. With LOX, we are able to achieve 99.5%. But from a clinical perspective, there's really no extra benefit between these two methods if you have the appropriate delivery channels. The patients will get really equally good benefits. From what I've read so far, and I've read extensively about this, because one of the main challenges that we got in Kenya was that BOC, the main manufacturer at this point,
Excellent, thank you.
went to the government to advocate. Yeah.
Oh, keep going. We just lost you for a minute.
Yeah, so I was joining using a phone and someone was trying to call me. So they did advocate for oxygen guidelines to require that medical oxygen be 99%. So we had to find a very technical way of responding. And with the Kenya Society of Anesthesia, Kenya Pediatrics Association, the Critical Kenya Society, we reviewed this matter extensively and came to a conclusion that there's actually no extra benefits when you're giving 99.5 versus anything above 90. And we are glad that the new guidelines from WHO are coming up with 90 plus, 93 plus minus 3 or something like that. So anything above 90 would be considered okay for any critically ill patient, even during ventilation. Thank you.
Excellent. And as a follow-up, there's a question about the difference between medical and industrial oxygen. Would you like to speak to that, or any of the other panelists? And I do want to point out, I recognize we're over time. If you have to leave, we are recording. We want to take a few more questions. Any of the panelists that need to leave, we certainly understand that we're at time, but if you can stay, that would be great.
So the difference between industrial and medical oxygen is really on just the steps that we take to make it medical grade. So then the additional filtration that you have to put in to remove all the microorganisms, including viruses, are not necessarily required when you are only producing industrial oxygen, maybe for firing up furnaces or things like that. So those plants can be rather rugged, and then also the handling of oxygen doesn't have to conform to the high hygiene or medical standards that you need to follow while handling medical grade oxygen. So a lot of the manufacturers, the large manufacturers, actually, most of the oxygen that they produce also goes for the industrial use. So because they're setting up very large plants, they don't differentiate. It's just that they now, when you're packaging the medical oxygen or the final finishing for packaging of medical oxygen, now you put it in a black container with a white shoulder as per the guidelines, and then the industrial one will be a fully black. So because of COVID, we saw at one point people were going to the steel factories to get oxygen to meet the gap. But after further discussion with the Ministry of Health, I think there was an agreement that the safety standards within those steel factories do not meet the medical standards. And there's a new direction to make sure that at least we don't give that oxygen that is primarily meant for furnace use into patients.
Thank you so much. This is for any panelists that would like it. There's some questions about the safety as well as the explosive nature of PSA plants. Would someone like to address that?
Sherry, I can just quickly say that the PSA plants, of course, need to be operated and maintained in a safe manner. PSA plants are not in and of themselves inherently dangerous or with risk, but oxygen is an accelerant for combustion, for fire. And if there is open flame or ignition source and a combustible material, an oxygen-enriched atmosphere can highly accelerate fire, which means that if oxygen is being exhausted or in and around the plant, that we want to make sure that there is no ignition sources, no open flame devices, no sparks, no smoking allowed, those kinds of things. But maintained in a safe environment, respectfully understanding the risks of oxygen to cause an acceleration of fire, but maintained in a safe environment, it should not be inherently explosive or combustible by itself.
Great, thank you. We have a lot of questions about calculating, and Jim Snuckle, this might be for you or anyone else on the panel, how to calculate the total demand for oxygen for a health facility and predict what the appropriate requirements are when people are ordering their PSA plans.
Yeah, Jim and Sarah spoke to the complexity of this was really essentially the same as the earlier question. And I would only say that we can write some guidelines and produce those so that everyone can get both the tools and the risks that Jim and Sarah pointed out before of either underestimating or overestimating the demand. I would like to make this point that from our experience in numerous countries, we've also discovered that the first best way to do the assessment is to talk to the clinicians that are in the hospitals, understanding their common patient load and what they know to be the demand for oxygen within their own clinic, whether it's a health clinic or hospital, department by department. When we're going to provide an oxygen plant, we would conduct that level of assessment. Now consider this additional factor, that we also find that in many hospitals, clinicians may not be trained to a very high level. And by providing clinical training so that clinicians understand best practices for administering oxygen therapy, we've seen an increase then in the demand of oxygen. The use of pulse oximeters to properly diagnose and understand the amount of oxygen that a patient needs and not over-oxygenate a patient is also an important factor. So there are a lot of factors that are at play here, and we can, I think, write some highlights and some guidelines for considerations. But I'd like to strongly advocate that your oxygen program also include a clinical training component, and that will typically increase the demand for oxygen within your local environment. Maybe one of the other panelists has something to add here, but that's.
Jerry, I agree with everything Jim said, and just want to add some additional complexity to it. One is that in hospitals where we have converted from cylinders to piped oxygen, we have seen in some cases a 300% increase in the use of oxygen because now oxygen is at the patient's bedside, and the clinician simply has to hook up a nasal cannula or a mask, and patients are getting low flows of oxygen much earlier and higher flows when they need it. So your oxygen consumption can often go up. Completely agree with Jim about talking to the clinicians. You have to understand the patient mix, the burden of disease. We have 7 different hospitals and surgical centers right now in design for pipeline that we're doing. And I am very involved in that. And we are wrestling with these every day, these issues every day, and they're not simple. Again, you got to look at the mix of patients, and we also would advocate looking at duplex systems, 2 smaller PSA systems, rather than a very large plant, because the compressors don't modulate. And as Bernard said earlier, electricity can be 70% of the cost of a liter of oxygen. It can be very, very expensive. Thanks.
I
Excellent.
would just like to add that there's a tool actually that Path and Chai have developed that you can use to feed in your patient volumes and bed numbers and patient characteristics. And then it automatically will give you an estimate of your oxygen requirement. I'm not so sure if this was just developed for Kenya, but I can reach out to my Path colleagues and Chai colleagues and see if it's something that we can share more broadly.
That tool is in the public domain. It's a great tool, very easy to use. However, I would say that you also need to check it against what your facility is doing in terms of clinical services and treatment. Because again, it is really complex to figure out. I wish it wasn't.
And Sherry, I'd like to add one more thing. For all that are on this call that are considering implementing oxygen systems, first of all, the direct pipe system, you don't actually have to have the PSA plant at your hospital for a direct pipe system. It can be supplied by cylinders. So not everybody is going to be able to have the benefit of an oxygen plant at their hospital, but the pipe system, I agree so much with Jim and Sarah. And honestly, I saw this first in partnership with Heratella in the hospitals that they were supplying that had piping. There was a 300% higher oxygen usage rate at those hospitals. And the reason for this is so simple in some ways. If someone has to go and pick a cylinder and bring it, it's heavy, it's time consuming, it's difficult, and it'll be delayed or it may be neglected altogether. But your patients will receive the best possible oxygen therapy if the piping is provided to the bedside of the patient. So that's really a strategic objective that those that are designing the oxygen programs should highly consider for the best possible service for the patient. Sherry, back to you.
Excellent. And Ms. Velez-Ruiz-Gaetan also mentioned in the comments that the distribution system also depends on if they're piping, filling cylinders, the working hours, and other factors that also are considerations on what size that you put for a PSA plant. I'm going to take one last question. It's a bit of a technical question, and then I think we're going to figure out a way to answer the rest of your questions in a different manner. I know it's getting late for a lot of you. Last question is from Karen Bahar, and it is, what is the conversion and compression factor of PSA plants to liters for cylinders, and how many standard cylinders can be in a, can you guys read this? 2 milliliter per minute. How many can it fill? What is the math behind it? Do we have calculations for figuring out
Sure.
the cylinders too? Yes.
Absolutely.
And so we'll send those out.
Yeah, we can provide those. The 42 liter cylinder is a very common large size cylinder. Some cylinders are a little bit bigger, typically not much smaller for large cylinders. And I would say that a really, really fast answer, close, would be if you had an oxygen plant that would produce at 32 cubic meters of oxygen per hour. At 32 cubic meters of oxygen per hour, you could expect between 100, 120 of cylinders of that size to be produced in a 24-hour period. That's a thumbnail idea. Go ahead.
And also heat, though, does cut down on that. If a manufacturer says that a plant fills 50, 20, 50, or 100 cylinders in a 24-hour period, we generally tell people to expect a maximum of about 80% of that in real life. there's also sort of sweet spots for the PSA plants, too small and too large, but in the middle is where you're going to get your best economy and lifespan.
Yeah, sure. And I really agree with what Jim said there, and that's in fact why I use the number 100 to 120. That's kind of the span. It's important because often the manufacturer will give you what the rated capacity of the plant can be, and that would mean it's operating every minute of every hour of the day. And go ahead, Jim.
Sorry, one other really important thing. All these plants are rated at 1,000 feet above sea level or lower.
Yes.
As you go up beyond 1,000 feet, as much of sub-Saharan Africa is, especially Kenya, you have to derate the plant significantly.
Excellent. There are so many questions and so many details, as you all can see, for establishing a PSA plant or any type of oxygen delivery system. We're going to put up on the screen our contact information. If you guys have additional questions, we're capturing all of the questions from this seminar. We will do our very best to answer them. All of the panelists stand ready to help provide technical assistance as best that we all can, as we all face together this terrible and dire need around the world for oxygen. We really appreciate all of your time here. If there are additional questions that you have, please reach out to the email on the slide. That's info@assistinternational.org. We will do our very best to continue to provide technical guidance for all of you as you establish PSA plants and other oxygen delivery systems. I would like again to thank the Caterpillar Foundation for sponsoring this seminar, Invest India for participating and for sending out the invitations. And we will record this. We are going to send out an email to you with many, many links and with presentation slides for your review, and then continue to try to help as best that we can. Thank you all for being on. Thank you to our panelists for your wealth of knowledge that you have shared. And I know that there's so much more that all of you can share as we work through this problem together. Thank you very much. Goodbye.